Papillary versus follicular thyroid cancer, key differences and clinical outcomes. Papillary and follicular thyroid cancers represent the two most common differentiated malignancies affecting the thyroid gland, with distinct histological features and clinical behaviors that influence treatment strategies. Introduction to differentiated thyroid cancers. The thyroid gland, situated at the front of the neck, produces hormones essential for regulating metabolism and supporting normal growth and development throughout the body. When malignant cells develop within this gland, they are classified into several types based on their cellular origin and microscopic appearance. Among these, papillary and follicular thyroid cancers represent the most frequently encountered malignancies, together accounting for the vast majority of thyroid cancer diagnoses. Both belong to a broader category known as differentiated thyroid carcinomas because their cellular characteristics retain some similarity to normal thyroid tissue. Understanding the distinctions between these two cancer types is crucial for patients and healthcare providers, as these differences directly impact treatment approaches, surveillance strategies, and long-term health outcomes. Histological and cellular characteristics. The primary distinction between papillary and follicular thyroid cancers lies in their microscopic appearance under the pathologist's microscope. Papillary thyroid carcinoma is characterized by cancer cells that form papillae, which are finger-like projections that create a distinctive branching pattern when examined histologically. These cells typically demonstrate elongated nuclei with a characteristic pale appearance, often described as empty or ghost-like nuclei. Follicular thyroid carcinoma, conversely, displays cancer cells organized into follicles, small, round structures resembling the normal functional units of the thyroid gland. The follicular architecture is preserved to varying degrees depending on the cancer's grade and differentiation level. This fundamental histological difference requires different diagnostic approaches and has significant implications for how these cancers spread and respond to therapy. Patterns of spread and metastasis. Papillary thyroid cancer demonstrates a distinctive pattern of lymphatic spread, particularly to regional lymph nodes within the neck. Many patients with papillary carcinoma will develop nodal metastases, and in some cases, cancer cells can be found in lymph nodes even when the primary tumor is relatively small or confined to the thyroid. Despite this frequent nodal involvement, papillary thyroid cancer generally exhibits a favorable prognosis with slow growth characteristics. The cancer's tendency to involve lymph nodes early has made regional lymph node assessment an important component of surgical planning. Follicular thyroid cancer, by contrast, demonstrates a greater propensity for hematogenous spread, dissemination through blood vessels to distant organs such as the lungs, bones, and liver. This difference in metastatic behavior is clinically significant, as it influences the urgency of treatment and the sites where healthcare providers must monitor for disease recurrence. Diagnostic approaches and challenges. Diagnosis of papillary thyroid cancer typically involves fine needle aspiration cytology, a minimally invasive procedure where a thin needle is inserted into thyroid nodules to obtain cell samples for microscopic examination. The characteristic nuclear features of papillary cancer cells can often be identified during this evaluation, allowing for relatively confident preoperative diagnosis in many instances. Follicular thyroid cancer, however, presents a more diagnostic challenge. Fine needle aspiration samples cannot reliably distinguish between benign follicular adenomas and follicular carcinomas, as both display similar cellular patterns. The critical distinguishing feature, invasion through the tumor capsule into surrounding tissues or blood vessels, can only be definitively determined by examining the entire lesion under the microscope during surgical pathology assessment. This diagnostic limitation means that patients with follicular lesions of uncertain potential often require surgical intervention to determine whether malignancy is present. Frequency and epidemiology. Papillary thyroid carcinoma is the most common thyroid malignancy, representing approximately 80 to 85% of all thyroid cancer cases. Its widespread prevalence makes it the cancer that most thyroid specialists encounter in their clinical practice. The relatively high frequency of papillary carcinoma has generated substantial clinical experience and research data, contributing to well-established treatment protocols and prognosis estimates. Follicular thyroid cancer accounts for approximately 10 to 15% of thyroid malignancies, making it the second most common histological type. While less frequent than its papillary counterpart, follicular carcinoma remains an important clinical entity that requires distinct management considerations. The different frequencies of these two cancer types mean that most thyroid cancer patients will be diagnosed with papillary carcinoma, yet the subset with follicular disease requires specific attention to their particular disease biology. Prognosis and survival outcomes. Papillary thyroid cancer carries one of the most favorable prognoses among all human malignancies. When diagnosed at early stages, 10-year survival rates exceed 90%, and many patients live normal lifespans without disease-related mortality. Even patients with advanced papillary carcinoma tend to have better survival outcomes compared to those with other thyroid cancer types. The slow growth rate and limited aggressive behavior of most papillary cancers contribute to these excellent long-term outcomes. Follicular thyroid cancer demonstrates variable prognosis depending on several factors, including tumor size, extent of invasion, and histological grade. While many patients with follicular carcinoma also experience favorable long-term survival, the cancer's propensity for distant metastasis and potentially more aggressive behavior results in slightly less favorable overall outcomes compared to papillary cases. Age at diagnosis, extent of disease, and molecular characteristics also influence prognosis in both cancer types, necessitating individualized prognostic assessments. Surgical management strategies. Surgical treatment forms the cornerstone of management for both papillary and follicular thyroid cancers. For papillary carcinoma, the surgical approach ranges from thyroid lobectomy, removal of one thyroid lobe, for small, low-risk tumors to total thyroidectomy, complete removal of the thyroid gland, with lymph node dissection for larger lesions or those with evident nodal involvement. The decision regarding extent of surgery depends on tumor size, patient age, extent of nodal disease, and other risk stratification factors. For follicular thyroid cancer, total thyroidectomy is more commonly performed as the initial surgical procedure, as the potential for distant metastasis necessitates subsequent radioactive iodine therapy, which requires complete removal of thyroid tissue. Careful surgical technique in both cases aims to achieve complete tumor removal while preserving important nearby structures, including the parathyroid glands and laryngeal nerves. Radioactive iodine therapy. One of the distinctive advantages of differentiated thyroid cancers is their ability to absorb and concentrate iodine, a property that normal thyroid tissue shares with these cancer cells. This biological characteristic enables treatment with radioactive iodine, iodine-131, which delivers targeted radiation to eliminate any remaining thyroid tissue and cancer cells throughout the body. Papillary thyroid cancer patients typically receive radioactive iodine therapy if they have lymph node metastases, distant metastases, or other higher-risk features, though many low-risk patients may be spared this treatment. Follicular thyroid cancer patients, particularly those with distant metastases or significant invasion, more frequently receive radioactive iodine therapy due to the cancer's predilection for hematogenous dissemination. This therapy cannot be administered to thyroid cancer patients who lack iodine uptake capability, making the differentiated status of these cancers a critical therapeutic advantage. Modern approaches carefully balance the benefits of radioactive iodine in eliminating cancer cells against potential side effects from radiation exposure. Molecular and genetic considerations. Advances in molecular biology have revealed distinct genetic alterations associated with papillary and follicular thyroid cancers. Papillary carcinomas frequently harbor mutations in the RET/PTC genes, BRAF gene, or other signaling pathway components that drive cancer development. These molecular patterns contribute to the papillary cancer's characteristic growth pattern and response to therapy. Follicular thyroid cancers display different molecular profiles, often involving mutations in genes such as PAX8/PARG fusion genes or other alterations that promote follicular differentiation. Understanding these molecular differences has begun to inform targeted therapy approaches for patients with advanced disease who no longer respond to radioactive iodine. Some patients with specific mutations may benefit from tyrosine kinase inhibitors or other molecular-directed therapies that interfere with cancer cell survival pathways. Molecular testing is increasingly incorporated into the initial pathological assessment to provide prognostic information and guide therapeutic decisions, particularly for higher-risk patients. Long-term monitoring and surveillance. Patients treated for papillary or follicular thyroid cancer require long-term surveillance to detect any recurrence or new disease development. Surveillance strategies typically include periodic thyroid hormone measurements, thyroglobulin blood tests, a protein produced specifically by thyroid tissue, and imaging studies such as ultrasound or radioactive iodine scans in selected cases. Papillary carcinoma patients generally require less intensive surveillance compared to those with follicular disease, particularly if they had low-risk disease at diagnosis. Thyroglobulin levels serve as a sensitive tumor marker for both cancer types, with rising levels potentially indicating cancer recurrence. The duration of surveillance recommendations varies, with some patients requiring monitoring for decades or even lifelong. Additionally, patients require thyroid hormone replacement therapy after total thyroidectomy, necessitating regular assessments to maintain appropriate hormone levels while avoiding excessive hormone supplementation that could stimulate any remaining cancer cells. Treatment of metastatic and recurrent disease. When papillary or follicular thyroid cancer progresses despite initial treatment, management options depend on whether the cancer maintains the ability to concentrate radioactive iodine. Patients whose cancers become unresponsive to radioactive iodine refractory disease, face more limited therapeutic options but may benefit from newer molecular targeted therapies. Tyrosine kinase inhibitors and other small molecule inhibitors have shown activity against advanced thyroid cancers and can slow disease progression in some patients. External beam radiation therapy may be considered for specific sites of metastatic disease causing symptoms or threatening critical structures. Chemotherapy plays a limited role in thyroid cancer management compared to many other malignancies. For patients with papillary carcinoma and limited metastatic disease, particularly if the cancer remains iodine-avid, radioactive iodine therapy remains an effective treatment option even in the metastatic setting. Multidisciplinary care involving thyroid surgeons, endocrinologists, nuclear medicine specialists, and medical oncologists ensures comprehensive management of these complex cases. Quality of life and patient considerations. Beyond the medical aspects of treatment, patients with papillary or follicular thyroid cancer must address quality of life considerations related to thyroidectomy and long-term management. The removal of the thyroid gland necessitates lifelong thyroid hormone replacement, though most patients tolerate this well with appropriate dosing adjustments. Some patients experience fatigue, weight changes, or mood alterations related to hormone replacement, requiring careful optimization of therapy. Surgical complications such as injury to the laryngeal nerves affecting voice quality or hypoparathyroidism affecting calcium metabolism can impact quality of life in a subset of patients. The excellent survival outcomes for most papillary and follicular thyroid cancer patients mean that many individuals live decades following diagnosis, making quality of life considerations during this extended survival period increasingly important. Psychological support and counseling can help patients adjust to their cancer diagnosis and manage anxiety related to long-term surveillance. Patient education regarding their specific cancer type, treatment rationale, and surveillance requirements empowers informed decision-making and engagement in their healthcare. Thank you for watching. For the full article, visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.